Hello and welcome everyone to tonight's webinar, the first in a series of 6 physiotherapy musculoskeletal webinars brought to you by Capital Health Network and a multidisciplinary team of hardworking health experts, including physiotherapists, psychologists, specialist pain and sports physicians, and orthopaedic surgeons. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. Tonight's webinar focuses on ankle and lower limb conditions, including lateral ankle sprains, high ankle syndesmosis sprains, Achilles tendonitis, and plantar foot pain. I am Dr. Leonie Harcourt, a GP educator advisor at Capital Health Network. Also with me tonight is Sam Jeffrey, a physiotherapist, Dr. Saqib Zafir, an orthopaedic surgeon, and of course, Kunal Mohiti from the events lead at Capital Health Network. All participants have been muted. So I saw there was a couple of questions about that in the chat box already. So you've all been muted, apologies. Please type any questions into the Q&A section of your Zoom panel, not the chat box. So the Q&A section is the place to type your questions. And we'll have a Q&A session after both Sam and Saqib have presented. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. Regarding CPD, please fill in the post-evaluation survey. CHN will email you a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home. Before we start, I just want to highlight the Health Pathways website, which has guidelines and advice on the treatment and investigation of many conditions, including lower limb injuries and conditions. The login is together, and the password is for health, FORHEALTH, all lowercase. Health Pathways are a reliable source of up-to-date clinical and referral information localized to the current area, but we appreciate your feedback in finessing and refining them. So there's a feedback tab at the bottom of every health pathway. So on to the presenters. Our first speaker tonight is Sam Jeffrey. Sam is a physiotherapist at Capital Clinic Physiotherapy, City West. Sam has a special interest in foot and ankle conditions. He has undertaken further training in the field, including development courses and time observing foot and ankle surgeries. Over 1/3 of his patient load comprises foot and ankle injuries and complaints. Sam believes that the foot and ankle offer complex challenges for patients and healthcare providers, and he hopes to provide a high level of diagnostic and rehabilitation skills to this niche area of physiotherapy. So over to you, Sam. Thank you very much.
Thanks, Leonie. I'll just share my screen. Sorry, 2 seconds. That's better. Alrighty. So, what I'm going to present on today are common foot and ankle presentations, particularly those that come to physiotherapy, but also through GP practices. I'm just going to be giving a bit of a brief outline on a few of these because any of them on their own could warrant quite a large presentation. So we'll just touch on a few things. I'm largely going to outline the prevalence, the issues we tend to find with these conditions, how we go about diagnosing them, what we ensure to look out for and rule out, and when we may refer on for imaging or further intervention. A big part of what I'll focus on today is my approach to rehabilitation, particularly for these common presentations. So what we're going to cover. We're going to cover first lateral ankle sprains. We'll do a little bit on high ankle and syndesmosis sprains, although that kind of folds into lateral ankle sprains a little bit. We'll spend quite a bit of time on plantar heel pain, and then we'll finish off with Achilles tendinopathy, which should run into Dr. Zafar's presentation after mine. So lateral ankle sprains. These are the most common injury in sports and really common in the general population as well, with up to 70% of people reporting having a lateral ankle sprain in their lifetime. And not only are they highly prevalent, but they also have a really high recurrence rate with a reported twofold increase in risk of re-injury in the 12 months after an acute sprain. So due to the high prevalence of ankle sprains, and often what can be a general consensus from patients that an ankle roll isn't really a serious thing, we can see a lot of issues down the line for patients who suffer these and then don't seek medical treatment. And this makes it all the more important for not only kind of early intervention with physiotherapy, but just being aware of this. And we can always kind of look to get them in for treatment nice and early. So as I said, the problem is many of these don't present. So one study found that up to 55% of people who suffer an acute lateral ankle sprain do not seek professional or medical treatment, which realistically, like, that's an education problem regarding follow-up for patients and who they should see. Because when we consider other areas of the body, particularly something like the lower back, if a GP, physio, or other health professional mention the word disc, often a patient can have this catastrophizing response due to the perception of the severity that can come with lower back injuries. Whereas compared to
Sorry to interrupt you, Sam. Are you moving your slides? Because attendees are unable to see the slides moving.
Yeah, they've been moved.
We can't see. It's not even a presenter's mode. It's just we can see the first slide only.
Shall I stop sharing share again? We'll see how we...
Perfect. Yeah.
Good start. What about now?
Yeah, we can see the notes.
Fun. Sorry.
Thank you. Yeah, it's good. Perfect.
Can you see them moving now?
Yeah, but we can see your notes again, but things that should be fine again.
I can go without the notes. That's all right. I can just wing it off the presentation. We'll see how we go.
Yeah.
Let's just go from here. Is that better?
Yeah. Thank
all
you.
Right. That's okay. We'll go from here. So hopefully I can remember all my notes I've written. Where to go? Yeah, so the problem often with what we're seeing with these patients is that sometimes they aren't presenting. And what I was kind of getting to is whether or not these patients are being educated on what they need and what I guess the perception of the severity of their injury might be. So I was alluding that to something like back pain, where if we mention something like a disc, we get this really kind of heavy response from patients where if we say something like, oh, you've just sprained your ankle, or it was just an ankle roll, we can have the inverse effect in terms of kind of giving off to the patient that it's nothing to worry about or nothing too significant. Now, not at all am I suggesting that we try and place fear into any patients or anything like that, but often what we can find from something that might start as just an acute lateral ankle sprain is they can have ongoing sensory motor deficits, which can lead to further problems down the line. And one study has reported kind of 80% of ankle joint osteoarthritis as a result of like a previous musculoskeletal trauma, like something like a lateral ankle sprain. And these patients being on average 10 years younger than the typical osteoarthritis ankle patients, which again poses problems and potentially further intervention and surgery down the line. When it comes to diagnosis of these, so when they do actually present, most of our diagnostics, we can get a lot just from the subjective history based on the kind of mechanism of the injury, with most patients suggesting they kind of just roll their ankle and the bottom of their foot turns in, which we are calling an inversion sprain. We can also get a plantar flexion plus inversion sprain, which is when they come up onto their toes and also roll in. And then there's contact and non-contact. With lateral ankle sprains, it's much more common to have non-contact. Contact could also be jumping up for a rebound or something like that and landing on someone's foot and rolling their ankle. We also really want to know the history of previous ankle sprains. How many, how recent, how severe, because not only would this help us determine potentially their return to function, their return to walking, their return to sport, whatever this patient might be doing, that it will give us a bit of an idea of, do they have any ongoing sensory motor issues from a previous sprain that we'll need to address in rehab. And this is why I think that ankles do have such a high recurrence, is because often these aren't really being addressed, and we might treat them as just an ankle sprain when they actually have these issues that have been coming along before then. Weight-bearing status straight after the injury and when we see these people is really important as well, which is going to inform our bone assessment, where we use our Ottawa ankle rules, which I'm sure everyone uses and knows, but I'll go over them quickly and then next slide. And then we do a ligament assessment, among many other things, but in the ligament assessment, we're just trying to determine which ligament, or if both ligaments of that lateral complex have been disturbed. So we have in the picture shown an anterior draw, which is looking to find the laxity and the pain in the ATFL ligament. And then we can do an ATFL and CFL stress test, which just looks to stress those ligaments, which can give us an idea on grading and how long we think that person might be back to sport, or if they need to be immobilized in a boot. It just helps us make those decisions. So the Ottawa ankle rules. So this picture's quite a nice way to have a look at it. What we want to do is we want to use these rules to make sure that we're not missing any ankle or midfoot fractures, but also to make sure we're not sending people for unnecessary radiographs. So the way it works, typically if someone comes in, if they have pain in the malleolar zone, so looking just around that malleolus, and then on palpation of the distal 6 centimeters of the fibula and lateral malleolus, or tibia and medial malleolus, we would consider that to be enough to say, okay, we need to get an x-ray, because then they're failing the Ottawa ankle rules. If, let's say, for instance, they have that pain in the malleolar zone, but they don't have tenderness on palpation of that part of the malleolus and tibia or fibula, then it's their ability to take 4 steps immediately after the injury and in the clinic. And if they're failing those, we're sending off for an x-ray, looking for potentially, or looking to rule out a fracture. We also use it for midfoot fractures. So same thing, particularly on syndesmosis and lateral ankle sprains, we want to be aware if someone's reporting midfoot pain after that. So if they come in reporting midfoot pain, and then we palpate along the 5th metatarsal head, if they have any pain there, that would warrant a fracture, an x-ray, or along the navicular. And then same rules for the weight bearing. If they weren't point tender on those bones, but then they failed the weight bearing, 4 steps immediately after or in clinic, we'd be sending for an x-ray. So the Ottawa ankle rules have been found to be highly sensitive in terms of being able to rule out fracture, particularly in adults, a little bit less sensitive in 16 years and below, but really quite good, and something that we can use to make sure we're not only not sending people for unnecessary x-rays. I think the evidence, which was on that notes page, which I can no longer see, is it reduced ankle radiographs by 28% and foot radiographs by 14%, but also it's going to make sure that we don't miss anything that might otherwise go undetected, like a small fracture. So rehab. When it comes to rehab, particularly in something like a lateral ankle sprain, it's multifaceted in what we want to address and then where we want to go with it. First and foremost, we want to see how that person's tolerating anything with pain, swelling. And if we determine if we need to do any immobilization as a result of their pain, whether that's a walking boot or crutches, if taping is necessary, what can we get them doing straight away in the way of movement, range of motion? Can they tolerate any strength straight away? Would massage be an option? We just want to get early intervention, usually as quick as possible if we can, to see what we can do to get the process moving. Then what we're going to look to in rehab, and what we'll do for, I'll sound like a broken record for all of these, is but looking impairment based. So does the person have reduced balance as a result of their injury, or weakness, or reduced proprioception, range of motion, particularly into dorsiflexion, and then pain, exercise tolerance, and capacity? Because what we then want to do is address those before we want to send someone back out to an activity where they have any risk or higher risk of re-injuring themselves. And we will look at those things through functional activities like walking, running, squatting, balancing, uneven surfaces, calf raises, lunges, squats, all of those things to get a nice picture of where that person is and how they're moving. When it comes to return to sport or returning to that person's previous level of function after an acute sprain, we need to make sure there's a plan. Particularly when it comes to return to sport criteria, there's not very good evidence around what exact criteria we should be using for someone who, let's say, rolls an ankle playing basketball. So I find for a patient like this, given the recurrence rate and how common they are, that if you have a plan in place and you tell them what they need to achieve before they go back to their activities, you get high compliance in terms of what they're willing to do in their rehab, and they have direction. You know, I don't think many people like just doing rehab for the sake of rehab or doing calf raises X amount just because that's what they're told to do. It's nice to give them a plan on where they're going. And I myself have a particular return to sport criteria for different sports, depending on the person, or even if it's just they want to get back to walking. So I think really having a nice plan in that way will help guide that rehab. Alrighty, so moving on to high ankle syndesmosis sprains. So we'll spend the least amount of time on this because it somewhat ties in terms of some of the rehab stuff with a lateral ankle sprain, but still worth covering quickly. So they account for approximately 12 to 17% of ankle sprains, and they similarly have a high recurrence rate to lateral ankle sprains. One thing I've found in clinic with these is they can frequently go undetected, particularly if they're a lower grade syndesmosis injury, and can cause kind of delayed return to play or function and ongoing ankle symptoms, particularly those deficits in sensory motor. So often, or not often, but sometimes I'll see a patient who's been treated as a lateral ankle sprain that's still having problems that you wouldn't expect of someone that far down the road, and there might be suspicion of potentially there was something more high ankle going on, which has disrupted their stability and they've gone back to sport too soon. So they have these ongoing issues. When it comes to diagnosis, again, we use similar process in terms of subjective history is really important, getting that mechanism of injury. In differently to a lateral ankle sprain is what we're seeing on a high ankle is more of a foot external rotation, or more rare, but can happen as a hyperdorsiflexion. Most commonly, particularly in contact sports, rugby league, rugby union, you see the kind of foot plant and then someone land on the outside of the leg, which causes this big external rotation moment at the foot, which can disturb those syndesmosis ligaments. Again, we will be asking history of previous ankle sprain to determine if they have any issues prior to this and what might extend their rehab out further. Same auto ankle rules. There's usually a higher chance of fracture in a syndesmosis sprain, so I want to be making sure we're always doing those and checking on their weight-bearing status. They're also more likely to require immobilization early on. And then ligament assessment is different because we're stressing different ligaments, but in the picture you can see a squeeze test, which is squeezing the tibia and fibula together to compress those ligaments. We have an external rotation and dorsiflexion, which is just mixing the two mechanisms of injury to stress those ligaments. And then there's also a fibular translation, which I don't do much of, but the idea is translating that fibula posteriorly should stretch the syndesmosis between the fibula and tibia. Rehab. So as I said, we're spending the least amount of time on this because a fair amount of overlap, but you're more often likely to need immobilization. And then depending on how you go diagnostically with these and what grade we're thinking these are at, we were more likely to require imaging, particularly if we're suspecting instability. Typically a grade 1 syndesmosis injury won't have much instability. A grade 2 syndesmosis injury can have quite a varying rate of instability, but will typically require more immobilization than something like a higher grade lateral ankle sprain. And then a grade 3 syndesmosis injury, we're typically making sure we get a surgical consult with someone like Dr. Safar, and he might be able to talk to that if there's any questions, but otherwise that might be in a future presentation. But the same rules go for rehab. We're looking impairment based. What is the deficit of the patient? How can we improve that? How can we improve pain and function by specifically giving exercises or movements to address those? And then, as I said, these tend to take longer. They tend to extend a bit longer than the normal healing timeframes for what we might expect, because there can be that level of instability early on, and potentially if it's requiring immobilization for a longer period, then you're also dealing with stiffness and things of that matter. All right, so planning heel pain. We'll probably spend the most time on this because there's quite a lot, but also when it comes to rehab and treatment options, it's just vast. So we'll talk through some of the evidence, some of the anecdotal evidence I've seen, some strategies, and realistically where we want to focus our energy when it comes to these patients. And Dr. Zafar is also going to talk to plantar fasciitis later on as well, so that'll help. So they account for approximately 11 to 15% of foot pain injuries that require treatment in adults, and the highest incidence is typically runners or the middle age, kind of the 40 to 60-year-old range, and females. And then also one study shows that it can present bilaterally in almost a third of cases, with which when we talk about plantar fascia pain, plantar heel pain, presenting bilaterally in a third of cases is quite a lot for such an injury or a pain that is really limiting and can also extend to such a large period of time. So the problem, approximately 75% of cases resolve within 12 months and approximately 5% require surgery, which seems pretty good, you know, three quarters in 12 months, but 12 months is a long time. And that obviously means that more than that go beyond that. A different study found 11 to 18% of people continue to report symptoms beyond 1 year. So we're kind of looking, I guess, in that 11 to 25% beyond 1 year, which is a long time to have a condition that is as pain limiting as plantar heel pain can be. And there's usually significant time lost to activities as a result of this. So usually talking many months to a year or more, as opposed to something like weeks. So I find in particular with patients presenting with plantar heel pain, if this is the pain source and we're sure of that, early education, early advice that this is a long process, but there are things we can do to change and mitigate pain along the way is really important. I find, and I'll talk about it a little bit more in a future slide, that these are the type of patients that most people know someone that's had plantar fasciitis before. Most people will be like, oh yeah, my uncle said it takes a year, so I'll just wait it out. And realistically, it's not a good strategy, and we need to be good at advising and educating patients on what we can actually do in terms of intervention, and whether that be physiotherapy or podiatry or inserts into shoes. I'll talk through some of these, but there are definitely things we can do to address that. And then when it's not in the running population or the athletic population, particularly in older patients, affecting mobility can have quite large knock-on effects for other joints, kind of deconditioning. We tend to see people who have suffered with this for some time get quite weak through that entire limb. And then we're looking at risk of other tissues being sore and other issues going on up and down the limb. So diagnosis. So there's a lot that can go into what we might look at or test, and I'm only going to touch on some of them because I think it's more important to talk about philosophy and how we might want to treat something like this, and particularly where I find we can go wrong as health professionals, physios, GPs, whoever it may be. But mainly these patients present with an insidious onset of pain. Again, it could be bilaterally or in one foot, typically pointing to the heel area, usually more towards the medial side on the inside, particularly when you're palpating, like that medial tubercle of the calcaneus is usually quite tender on these patients, but it can go towards certainly into the arch in the middle of the heel. Palpation can be quite good for ruling in or out potentially differential diagnoses as well. Something like an insertional Achilles pain can be felt quite low down on the back of the heel, but not quite where you would feel plantar fascia pain, as well as something like a fat pad injury, which might have occurred as a result of trauma and landing on the heel quite hard. And then even if they're feeling pain more into their midfoot, ruling out anything potentially more sinister like a Liz Frank injury, we can do a lot with the mechanism and the palpation. We definitely look at gait in these patients, depending on if this is chronic, if this is ongoing, recurrent, acute. We just want to see what has changed. So in particular, when we're looking at gait, we're comparing left to right, which can be difficult if they have bilateral pain, but we still want to see what we think could potentially be adding to their pain. So we're looking at kind of foot position, whether that pronated, neutral, or supinated, stride length, where the pain is in their gait. Do they have any compensatory techniques at the hip and knee? Are they slapping their feet? Are they trying to pull their feet off the ground but not really propelling themselves forward? A lot of things we can go into there. And then we want to make sure that we're ruling out anything else that could potentially be causing that pain. So we use some neurodynamic tests and Tinnell's tests. So particularly because plantar fascia pain can be described as like a burning sensation, And we want to make sure that we've got the source of the pain correct, and we can do neurodynamic tests to raw tension, and we can do a TMUS test if we think that that's a potential pain source. Rehab. So this is by far, when it comes to the evidence and approaches, where you can see, if you just ask 20 different physios or 20 different GPs or different sports doctors, you'll get different answers, because there are so many options, and typically rehabilitation for someone with plantar heel pain is multifaceted. So what we do and where we go, I think, again, it's going to be really important, and it has to be not recipe-based, very individualized to each patient. A lot of that based on, that's what they want to get back to, but also what's going to work for them. So I'll run through these quickly, just to give a bit of a sense of how much they can be. And then for us who know enough about this and know the anatomy and some of the effects of this, think about how much that is for a patient to hear all of these different treatment options, some of which have varying evidence, some have very little, some have a lot, and it's just kind of a bit of water we have to wade through to try and get to the right treatment plan for someone. So stretching and strengthening is where I'll typically start, and there is, again, varying evidence on stretching for pain relief. So typically stretching through that plantar fascia, or potentially stretching through the calf muscle. Some people might get great pain relief, some might not. Strengthening, which is where I will spend a lot of my time if I feel it's necessary and if there are deficits there that need to be addressed, which again is impairment based. But largely what we're trying to do with strengthening for something like plantar fascia pain is make sure that the capacity of their tissues, the capacity of the muscles in their feet, the fascia, their Achilles tendon, their calf, their glutes, everything is going to be able to be ready for any activity they want to get back to. So if this is a runner who's got plantar heel pain and they've been out of running for 6 months and they've just been doing pain relieving techniques at their foot, and they go back to running, they are working with so much less as a result of that. We need to make sure that we're not just looking to strengthen the foot or just strengthen the calf. We want to strengthen that whole limb, because those are the type of patients that go out and come back with the same issue not too long afterwards. Advice and education, probably the most important here, and particularly I think communication between healthcare professionals who might be looking after someone with plantar heel pain, whether it be kind of GP to physio to podiatrist to specialist, to making sure everyone at least is on the same page so the patient isn't getting mixed messages, because as I said, there's so much that we can offer, and what might be right for someone might not be right for someone else. And we want to make sure that anything where, I guess, telling to a patient, we want to be reiterated by everyone else. But also with that is kind of what pain is okay, particularly if we are looking at rehab. We will tend to treat fascia, like a plantar fascia, like we would a tendon. So some of the protocols we use for an Achilles tendon, where we use to treat fascia as well, they're not a like-for-like structure, but it tends to work quite well in terms of progressive loading of the tissue to build its capacity. Ultimately, we're just trying to build the resilience of that tissue. Load management, which is really important. Ideally, again, we don't want people to become deconditioned prior to going back to their normal functions. So we're looking to modify their activity and not eliminate it if we can. And if we need to modify that by using things like taping or shoe inserts, we will do that if we can keep them active and moving without prolonging their recovery or damaging. We want to try and keep those people active and strong. When it comes to taping and shoe inserts and potentially something like a night splint, there are so many options. There are so many different taping techniques. Some work for some work for others. I personally have had quite a lot of success with a bit of a modified arch support type taping technique, which I find works really well if a patient's having a lot of trouble with pain as they're kind of pushing off when they walk. This tape basically propels them forward a little bit and gives that fascia a chance to kind of calm down as they're always walking on it. But there's so many, and different people try different ones. Shoe inserts can be really helpful, whether that be something that's $40 to $60 off the shelf and straight into their shoe just for some support, or that be kind of a consult with a podiatrist to get a customized insert for their foot. Again, I think giving patients the evidence and the autonomy to be able to make these decisions is really important. So if you say to someone, look, we can try stretching, strengthening, load management, you can try a bit of tape, you can get a shoe insert off the shelf, you can get a gel cup for your heel, you can try this and that, or they say, look, I don't want to try all these different things. What do you think is the best option? You might say, well, this might be the most expensive, but might give you the most. And that might be something like, we do a strengthening and stretching program with Physio for X amount of months, and you see a podiatrist to get a custom-made insole for your shoe. But I think at least giving the patient the option to choose and say, well, I want to try potentially the cheap option that still might work against the expensive option, or they might say, I want to try all of it. I'm so sick of this pain, because this can be such a painful injury. And there's also night splinting, which can be quite helpful. Again, I probably don't do this as much, but tend to do it more for people that are having a lot of trouble in terms of pain, but also just responding to rehab, responding to physio. They've tried many things, and the night splint just looks to kind of keep that plantar fascia stretched over night time, so it's not so the front of that foot isn't relaxing and then giving us that contraction through that bottom of our foot. Because typically these patients' first steps in the morning are the biggest problem, or where they notice it immediately, and then that's them for the rest of the day. Then we have surgery, PRP injections, shockwave therapy. Again, like it's just to say that there's so many different options, and these all do have varying evidence, which is why I think it's so important to make sure that we are always chatting to the patient on exactly what they want and what their options are and what we think is the best way forward. That what informs these interventions, particularly kind of surgeries and injections, I'll let Dr. Zafar talk about next, might be X amount of time trying conservative rehab with physio that hasn't got you very far, so we need to do something else, we need to move forward. And then there's shockwave therapy, which again has varying levels of evidence, but anecdotally, some people say, you know, amazing, helped my pain so much, and others say I didn't get much effect. So again, it's just a bit of trial and error sometimes with these. Alrighty, last one is Achilles tendinopathy, and I won't keep us too much longer on these, but we see a lot of these, particularly runners. So it's estimated that the risk of Achilles tendinopathy in runners is 10 times that of the sedentary population. And that's because this is typically an overload issue that we're finding, particularly when we're seeing these kind of reactive Achilles. One study indicated that elite male runners, Achilles tendinopathy has a cumulative lifetime incidence of greater than 50%, which again just means we're seeing a lot of these, particularly in runners. And then the prevalence tends to be those above 45 years old or runners, and then the lowest is under 18 years old, which again speaks to that kind of overload nature of how we see these injuries. So much like a lot of these we've talked about, there is a high recurrence rate in Achilles tendinopathy, with some studies indicating up to 44%, and then also a possible link to Achilles rupture in tendinopathic tendons. Again, this is a bit varying across research. There was a paper I read that said that when you kind of MRI, or when we're scanning that tendon prior to doing something like an Achilles surgery, there's history of tendinopathic tendon around that. Now, does that mean that that caused a rupture, or is that just because frequently those who rupture their Achilles are quite athletic and they're probably likely to have tendinopathic tendons? It's hard to say, but there's something there. And typically there's significant time lost to activities and pain with mobilizing, kind of a lot like plantar heel pain. And again, recovery time, particularly those who want to get back to where they were before, is months, not weeks, usually. Some people might get there quicker depending on where they're at in their cycle. The one thing I find though, and the problem with a lot of the patients I tend to see, particularly if I'm seeing someone who's had multiple failed returns to running or something, or is wanting a second opinion, is that they are significantly under-rehabilitated, I find, Achilles tendinopathy patients, and they get back to running way too quickly, or too high a load way too quickly. I'll go through a little bit of that in the rehab. Diagnosis. So again, mechanism of injury is really important. Typically, this is an insidious onset, or usually if you can tease it out with questions, these patients present after a peak in load, whether that be running or going from sedentary just to doing lots of walking or changing shoes. We usually see a rapid change or a rapid load change. We just want to make sure that we're also ruling out something like an Achilles rupture or something like that. So want to be checking for that, which can be done with the Thomas test. 24-hour pain behavior. So particularly these patients will tend to say, you know, it's sore in the morning, it warms up, it's okay, it gets sore again, and it's really sore. Or it's sore at the start of my run, it warms up for a couple of kilometers, then it gets sore towards the end of the run, and then it's sore to walk the next day. That kind of pattern going like that for their tendons. Palpation can again help us rule in or rule out anything else that might be going on. So again, if that pain's actually more under their heel and we're thinking more plantar fascia, if it's down towards right the back of the heel, it could be more insertional Achilles, which might just change our rehab a little bit, or mid-portion Achilles or moving higher up. Same thing, we like to look at tests and see the quality of the movement. So we're looking at calf raise, squat, lunge, walking on their toes, run, jump, hop. Are any of these too painful? Do any of these look different to the other side? Comparing side to side, always really important, because again, the high recurrence rate of Achilles tendinopathy and how often people are presenting with it tells me that there's probably something we're doing a little bit incorrectly with these. So rehab. So a lot of Achilles rehab, and this is my last slide, by the way, is around trying to manage the training loads of the person and then the capacity of the tissue, how strong that Achilles is or how willing it is to take on some of these loads. What we want to look at when it comes to strengthening is particularly not just strengthening the calf. Again, like I said, with plantar fascia pain, we want to be looking to see if there's anything else in terms of that leg and the hamstring or glutes that's affected. Typically it will be. So making sure that we're addressing the source, but not addressing any secondary issues. Advice and education becomes really important when it comes to tendon loading, because I said that we kind of want to treat the plantar fascia like a tendon, although it's not the exact same. But when it comes to tendon behavior, we have some good research now that suggests that there's a progressive way to load a tendon, how much pain where we should allow people to train within to actually get adaptation of the tendon, how long they should rest for. So when it comes to our advice and education around our rehab, I like to be really kind of strict on what I want them to do, how much I want them to do, how much is too much, how much is too little, what pain's acceptable, just so they have about the sense of what they're doing is helping and when they've gone too far or not gone far enough. Load management, again, looking at modifying their activity, ideally not completely eliminating it, but that's not always the case, and we can potentially use something like taping and shin inserts to allow them to continue doing their activity at a reduced rate. So something like a heel raise can be really effective for someone with Achilles tendon pain, because just raising that heel just reduces the stretch on that Achilles, which can really help. Shoe change might be necessary if the person has a really old shoe or it's not particularly supportive of them. And as I said, I have a taping technique that I like to use for propulsion that can really help with unloading that Achilles. And then looking towards potentially something like surgery or injections if physiotherapy is failing or if their pain's too great or we can't get them where they need to be. And again, Dr. Zafar can talk to what might inform these interventions when he might think that that's a reasonable place to go. But largely when it comes to tendinopathy, particularly of the Achilles and lower limb, my experience with patients is that almost all of them go back too soon, and whether that's kind of physiotherapy led or whether healthcare professional led or the patient has made that decision, they will typically always kind of represent later on. Because if someone has gone from, let's say, doing 40 kilometers of running a week, 50 kilometers, whatever it might be, and we rest them from running for 6 weeks and all they've really done is calf raises, I don't think that Achilles is now all of a sudden equipped to go and handle 50 kilometers of running again. There is so much in that process that we tend to skip over really quickly. And I find that letting them know early, letting them know that this is what we have to do and saying this can be the potential outcome if we don't do it can be helpful to get buy-in on it, because usually this occurs in runners and runners just want to run. So I find early education and making sure that they know that we need to go through stages where we're actively loading that tissue over a long period of time to make sure it's capable to do the activity we want to get them back to. I find that for the most part in the foot and ankle, the education and advice part is just so critical.
Thank you very much, Sam. And so I think the message for us, we're going to have questions at the very end. So please type your questions into the chat box. But I think the message for us was don't go back too soon. Just hold the patient back. They might be keen, but just let them know just to be patient. On to our second speaker tonight. So our second speaker tonight is Dr. Saqib Zafir. Saqib is an orthopaedic surgeon who specialises in foot, ankles and limb reconstruction trauma surgery. He has a strong academic research background and is actively involved in training junior doctors and medical students. He regularly instructs on EMTS, so early management of severe trauma. Sorry, I said EMTS, EMST, run by the Australian College of Surgeons, and has been appointed honorary clinical lecturer at the ANU. Saqib works closely with physiotherapists to ensure that his patients receive holistic, appropriate care. In 2022, he was awarded the Joint Surgical College's medal for the candidate who passes the examination with the highest score at the first attempt by the Joint Surgical Fellow Examination Speciality Board in Trauma and Orthopaedic Surgery in Edinburgh. So that sounds very, very impressive. Over to you, Saqib. Thanks very much.
Thanks, Leonie, and good evening, everyone. Welcome to this webinar. And I think Sam has laid down the foundation of my talk quite well, and I'm grateful to Sam as well. I'm going to restrict myself to, I'm just going to share the screen, and I'm just going to restrict myself to the Achilles tendinopathy and plantar fasciitis, because I feel that the topics is so vast, and if we cover everything, probably we may not be able to, if we try to attempt to cover everything, we may not be able to do it in this short period. And also, I will be very happy to take any questions at the end regarding the lateral ligaments or syndesmosis. And I've already spoken to Leonie that if need may be arising, I will hopefully be able to do these lateral ligament and syndesmosis in a different setting. So I will primarily focus on Achilles tendinopathy and plantar fasciitis. As we know that the reason we chose this topic is that this is one of the very common presentations in general practice. And in turn, it results in a quite large proportion of referrals to us as in Foot and Ankle Hub, me, to Sam, and also to our podiatrist Emma as well. And the effects of the Achilles tendinopathy and plantar fasciitis, as Sam already alluded to, they're quite significant in terms of discomfort and pain to the patient, in terms of the days lost to their work and productivity, in terms of their ability to do their day-to-day activities. And some of them feel so much pain that their nighttime sleep is affected, their ability to wear shoes, to be able to walk out with their dogs, or to attend some gatherings and party, and also in terms of running and walking. So it has an immense, not only the physical, but also the mental effect, health effect as well. So I will try to make it simple, and I would like to, in this my talk, I would like to address the most pertinent points for you guys, so that you understand that what is the anatomy and pathology behind it, and how it should be managed, and when to refer on. All of us know that Achilles tendon, it's the largest tendon in the body. It's actually originates from two muscles, which forms the bulk of the calf, which is gastrocnemius and soleus. And both of them form this thick, biggest tendon in the body, and it inserts at the back of the calcaneal tuberosity. Now, the reason I chose Achilles tendinitis and plantar fascia is that these two are strongly interlinked, both anatomically, and also we have noticed that the pathology, which is plantar fasciitis and Achilles tendinitis, has got a very strong link. And the new evidence is suggesting that in case of recalcitrant plantar fasciitis, we need to address the Achilles issues. So, and the anatomically, if you see that Achilles tendon then continues as plantar fascia in the sole of the foot. So if there is any pathology which is affecting Achilles, or is there any tightness of the Achilles, that will in turn will have an implication or bearing on plantar fascia, and that can lead to plantar fasciitis. And also plantar fasciitis pain, if it's not responding to conservative measures or routine therapy, then we need to consider whether the pathology is arising in Achilles. The plantar fascia anatomy-wise, it's, as Sam said, they're a bit different to tendon because it's just a connective tissue, and that supports the foot's plantar arch. And it originates at the calcaneal tuberosity of the hind foot, and then it inserts into the bases of the proximal phalanges of the toes. Now, the important thing to remember is that it has got three bands. One is the central band, the other is the medial, and one is which is a little bit ignored in our diagnosis and even in our radiologic investigation is the lateral band. The most common presentation with plantar fasciitis involves the medial band and to some extent the central band. And most of us have got this impression that if it's a plantar medial heel pain, then it's plantar fasciitis. But if there's an involvement of the lateral band of the plantar fascia, which starts from the calcaneal tuberosity and it inserts into the base of the fifth metatarsal, that can also lead to a painful plantar fasciitis condition, but the symptoms will be on the outer border or the lateral aspect of the foot. And because this lateral band of the plantar fascia inserts into the base of fifth metatarsal where peroneus brevis tendon is inserted, it can be confused with that pathology. So primarily, it's the medial plantar fascia which is most symptomatic, but it can present with a central or the lateral pain as well. Now, this is very important, this plantar fascia, because it supports the arch of the foot and it helps with an even load distribution. Now, both for Achilles tendon and plantar fascia, they are stress-bearing anatomical structures, and they respond quite remarkably to stress. And that means that if somebody is quite active and they are doing exercise, that will result in increase in the diameter of the tendon, will add more tenocytes, collagen matrix, connective tissue, and makes the tendon stronger. On the other hand, over-exercise with an inadequate tendon structure can put extra stresses on the tendon itself. And in that case, the exercise can have a negative impact on the tendon itself because it can result in more load or more stress to the tendon what it can bear. And the inactivity or immobilization leads to rapid atrophy of this tendon. And you've noticed that sometimes when we treat people with ankle fractures or those who have Achilles tendon rupture, and we place them in cast or cam boot, around 2 to 3 weeks, you will see a significant reduction in the bulk of the calf muscle. But it takes some time, but it responds very well to exercise, and the calf muscle bulk can be rebuilt. There is also some evidence that as with the aging process, there is reduction in the density of the cells, collagen fiber diameters, and their density. What it means is that the tendon quality deteriorates with aging. And the classical presentation of tendinopathy or plantar fasciitis are in the middle-aged people. And if we look at the rupture of Achilles tendon, that is usually a middle-aged father trying to compete with their teenage son or daughter in a soccer or a footy game. And this is, again, they have not been loading their tendon so well. Tendon diameter is reduced. The collagen density is less. Cell count has reduced. And tendon is not able to take even a sudden increase in stress, and it can either rupture or if it's happening over a period of time, it can develop tendinopathic changes. It's a 10 times body weight goes through these tendon, Achilles tendon, when somebody's running. So you can imagine the stress which this tendon is taking during the exercise. Now, there are different risk factors have been studied, and there's some associations have been found. And the main factors which we look at is, again, as I said, age is a main factor, where there is age-related reduction in tendon structures, and that can predispose to this tendinopathy. Hypertension has been associated with Achilles tendinopathy and plantar fasciitis. And there was a study done which looked at different factors and the association with this condition, and they found that in females, the hypertension has got strong association with Achilles tendinopathy itself. And then the diabetes is strongly associated, particularly in males who are younger males, like less than 45 years of age. And this is because the general effect of diabetes, because we call it as a syndrome, it affects everything. It affects the connective tissues, it affects the neurological balance, it affects the quality of the muscle, it affects the coordination, and the combination of all these can result in tendinopathy. Obesity is a very strong risk factor for developing tendinopathy and plantar fasciitis, and they found in their study that this has got equal association both in men and women. Steroid therapy, again, prolonged steroid therapy can cause a reduction in the cell count of the tendons and can make the tendons weaker, and they can predispose to tendinopathy. Estrogen exposure. So again, in women, people like on contraception and HRT, too much estrogen exposure has got a negative impact on tendon health, and that can lead to these changes of tendinopathy and pain and plantar fasciitis. And the other thing is that if there's overuse, gait and biomechanical abnormalities. And I think Sam showed a very nice picture of the alignment of their hindfoot. Normally, the heel should be in slight tilted outwards if you draw a line from the center of the calf. But if there is too much of the valgus, like we see in flat foot deformities, or if there's too much varus of the heel, as we see in high arch feet, which is the Caris deformities, they can put an extra stress on the insertion of the tendon and also on the plantar fascia, and they can predispose to the tendinitis and plantar fasciitis. There's a strong association of prolonged using of quinolone antibiotics like ciprofloxacin is well known to cause tendinopathy. So it's very important when someone comes in with these symptoms, we need to find out the associated factors which can be predisposing them to plantar fasciitis or tendinopathy itself. Now, one interesting thing is that when we did the histological examination of these tendons, which are painful and have got ongoing symptoms, or we've taken some samples during surgery, it is not an inflammatory mediated process. That was one astonishing finding. Although it is painful, but there were no acute inflammatory cells in the histological samples. Rather, the changes were consistent with what we call as a failed healing response. What that means was that there were degenerative changes both at the cellular level and also in the matrix level. There was, the collagen was coalesced, it was not properly organized, there was disordered collagen formation. There are different types of collagen, so the healthy collagen, which should be present in tendon, was replaced by an unhealthy collagen. There were changes of cystic mucoid changes, which is like a debris formed in the tendon itself. Calcification is found, which is quite painful as well. And there were infiltrates of blood vessels. So overall, what it felt like is that it's not like an inflamed joint or an inflamed tissue, which will show acute inflammatory cells. And healing and inflammation is actually an early part of the healing response. in the cases of tendinopathy and both plantar fasciitis, there was one characteristic feature was that the inflammation was not as marked as one would have expected with pain and the symptoms. Rather, what it was shown that it is a tendon which has been under due stress, unnecessary stress, or a tendon which has been affected by other pathologies, as I highlighted in my previous slide, and was trying to heal, but actually it did not manage to heal itself properly and result into a failed healing response, and that is resulted by degenerative changes. And I explain, I give an analogy to the patients when they come and see it, and I say that the analogy is like a disintegrating rope. But the rope is made up of a lot of fibers. But if it is disintegrating, then you will see that these fibers are tearing apart. It's creating a disorganized arrangement. And overall, you can see that the tendon is there. But when you look into depth in there, that rope or that fibers which are making the rope, in terms, they are the building blocks of the rope, they are started disintegrating. So this will be very important finding to actually help us decide how we're going to be managing these people, these patients, because we have to somehow initiate or help that healing response, which the body has been trying, but unfortunately, because of certain other factors, could not achieve that healing. And how can we support that healing? How can we trigger off that healing? And how can we control that healing one so that we can achieve a tendon which is strong enough to bear the stresses or demands of that specific individual? Sam has highlighted this one, but I'll just go briefly over this one, over the clinical presentation. They usually present with pain. And pain can be in the early phases, and it gets worse because if you see a failed healing response or a progressively degenerating tendon, it's going to be becoming weaker and weaker. And if the same level of stress, same level of trauma demand, same level of demand of activity will continue, it will inflict more trauma to that tendon or that tissue or plantar fasciitis. And that's going to be failing gradually, and a failing tissue then causes pain which can be multifactorial. May not necessarily be an inflammatory response as I highlighted, but it could be the mechanical failure or a fatigue pain or an adjacent tissue which is trying to support that healing that is showing inflammation, such as the bone to which the tendon or the fascia is attached. Or it could be some neurological pain associated with it. The classical history of either Achilles tendonitis or plantar fasciitis is an pain after periods of prolonged immobility. People will describe it as pain first thing in the morning when they get off the bed and try to go to either a toilet or a kitchen. The first few steps are really painful. Then it slowly eases off in early mobilization. But as the day passes and they get engaged into their daily activities, it gets worse. And towards the end of the day, the pain is really worse again, which is again showing that repetitive and cyclical loading, which is normal for that person. But because the tendon or the plantar fascia is degenerative, it's not healed there, it's progressively getting weaker. It could not cope up with those demands. They describe it as a sharp pain sometimes or a burning pain. And again, burning pain could be like, there's some theory about it would be like a local ischemic type pain. It gets worsened with activities such as walking and running. And it gets a little bit better when they take rest. But after a prolonged period of inactivity, when they take few steps again, it increases their symptoms and then eases off after that. They feel if the Achilles tendon is thickened, maybe nodularity there on a chronic process. In case of insertional tendinopathy, they feel this heel bump at the back, which is the prominent bony prominence at the posterior calcaneum. And when it becomes such a bigger bulk of the bone there, or the tendon is really calcified and become thickened, they complain of this difficulty in wearing closed shoes because the back of those shoes put a direct pressure on that tendon, and that makes the symptoms worse. After this one, the basic investigations can be very helpful in making a diagnosis of plantar fasciitis or the Achilles tendonitis. An X-ray, which is most of carried out in general practice as well, is sometimes shows quite pathognomic features of either plantar fasciitis or Achilles tendonitis. And I will address some myths about these spurs as well later in my talk. The main thing in the X-ray is to look at the lateral view. If you can see this radiograph of the foot, the white arrow is pointing to an area of calcification which is forming in the Achilles tendon itself. And where the Achilles has attached to the posterior tuberosity of the calcaneum, this calcification has actually organized into a well-defined osseous spur or a bony spur. And this bony spur is arising from the calcaneum, but it is actually in the tendon itself. What it means that the normal tendon, which is comprised of collagen, tenocytes, and extracellular matrix, has been replaced by bony tissue. And that is itself acting as like a sharp knife digging into the tendon itself and causing more microtrauma. And that more microtrauma leads to, again, microbleeding, and microbleeding leads to calcification, and it's a vicious circle which goes on. This is the same pain pathology as we see in shoulders with calcific tendinitis. And in the early phases of calcification, there may be some inflammation, and that's a combination of degeneration, vascular infiltration, hypoxia, tissue damage, overload, that is responsible for causing them the pain. Ultrasound is also a very reliable test if it's done properly in good hands. And in the general practice, I must say these two investigations, X-ray and ultrasound, should be enough and plus the clinical diagnosis based on the history and examination, that you will be able to make the diagnosis of plantar fasciitis and Achilles tendinopathy. MRI is a tertiary level investigation, and it helps in certain ways, particularly when there's a failed response to the initial treatment, when the diagnosis is uncertain and we are suspecting any differentials, or when we are planning surgery. And also, the MRI will help us to look at the structures adjacent to the Achilles tendon and its insertion. The main thing what MRI shows in case of Achilles tendinopathy, if you see the picture on the right, there is a fusiform thickening of the Achilles tendon that is for mid-substance tendinopathy. And the other on the picture on the left on the MRI scan is actually showing insertional tendinopathy, where the tendon is inserting at the heel. And you can see that this white area in the middle of the tendon is showing degeneration, where the tendon fibers are actually disappearing or they're being replaced by scar tissue. And you can see that this is causing inherent weakness in this tendon. And if the same load or activity continues, this will continue to expand, and that will eventually can cause more symptoms to the patient. Or I have seen some cases where on background of tendinopathy, there has been rupture. The other thing, this small white arrow in front of the Achilles is showing a fat pad, which is the posterior heel fat pad that has got some inflammation. Again, this is one of the pain generators for Achilles insertional tendinopathy. And again, this could be one of the reasons where the pain may not be responding to our simple measures. And if you have to consider an injection of steroid or something, it should not be in the tendon. It should be addressed to this fat pad. It's called as Kager's fat pad, but it's just sitting in front of it. And every time I've gone in for surgery for Achilles tendinopathy, I've found fluid, bit of bursitis tissue on the side, fat with some inflammation. And also, sometimes people have got this posterior process of talus bone, which is longer than in many individuals, as you can see on this picture on the right. And that can cause inflammation and pain as well. So MRI is useful in confirming the diagnosis, but its majority of its indication is when we have tried and exhausted the initial treatment and we are looking for some other source, which could be the pain generator. Principles of management, to be simple, if just to keep things simple, is that one is to control the pain and symptoms. The second is to offload that tendon, because this is a tendon which is failing in the load which is being exerted on. And it needs some time to revive, to heal. Remember, it's a fail healing response. So an offloading is going to give this tendon a bit more support, to just a bit more comfort to actually recover from that repetitive load which is being happening. And here, the roles of podiatrists come in, and multifaceted treatment, which I will discuss in next slides as well. Then what we need to do, as I said, is that either the healing response is weaker or the healing response has exhausted. So we need to stimulate that healing response and support it. And there are various methods of doing it, is by using physiotherapy adjuncts and other adjunct treatments such as shockwave therapy, platelet-rich plasma, improving the general health of the patient, modifying or controlling the other factors which are contributing, eliminating some of, as I said, some drugs like quinolones, steroids, anti-epileptic medication. All these contribute to tendinopathy. So we need to look into an adjuncts to support this tendon, to support this healing response. And we need to address those risk factors. Then rehabilitation is very important. And rehabilitation is a multimodal, multifaceted, and multidisciplinary approach. These conditions can sometimes be very difficult to treat, particularly if they become chronic. Imagine a 9 to 12-month period of pain, which is constantly affecting your quality of life. It's present right from the first step you take in the morning and becomes worse towards the end. You can't enjoy the activities you want to do. It could be quite debilitating. And it's not fixing in a week or 2 weeks or so. And like any chronic disease, patient compliance gets weaker. They get into sort of psychological issues as well with that. And they can be associated with loss of work, loss of earning. And it just has got all sort of this saga of social, mental health, and physical impact on these patients. So a rehabilitation is multifaceted and multimodal, and it multidisciplinary. It involves the role of podiatrists, role of physiotherapists, role of exercise physiologists, and surgeons coming at the end as well. And surgery is really an end-of-road option. Although it is successful, but it's an end-of-road option because of the risks and complications associated with it. And I'm going to take one by one each there. I must say that I said that there's no inflammatory response, and it's a failed healing response. But pain management makes an important aspect of care of these patients. And non-steroidals, although I am openly admitting that I could not find in histologically or biomechanical studies the role of non-steroidals and there's no biological basis for that, but they help with the pain control. And they can help pain control with, for example, like I showed that MRI where there was fat pad adjacent to tendon that is inflamed, or there's associated bone bruising, or there's some sort of ischemic pain as well. So they can help in achieving some pain control over there. So we should not undermine the role of pain management in tendinopathy and plantar fasciitis. But one downside is that if there's an early symptoms and we load them with painkillers, and patient's pain response is not amplified, and as Sam said, that there's an acceptable level of pain for the activity, then it can really lead to ignorance of these symptoms. And as said, it can trigger a vicious cycle where the tendon is failing under load, you're managing pain, the same level of activity continues without modifying the risk factors or without modifying the load which the tendon can take, then it can cause worsening of the symptoms. COX-2 in general should be avoided because of there's some negative impact on tendon healing, such as tenocytes and collagen formation. And I've also noticed that topical NSAIDs such as Voltaren gel is usually very helpful. Cryotherapy for me, what I mean is applying basically ice packs or frozen peas packs to the wound. And that is basically you're applying a cold stimulus to disrupt the conduction of pain signals. And that is helpful. And I normally advise people that it's towards the end of the day when they're feeling this aching pain before going to bed, a bit of ice packing at that stage, a bit of some rest and Voltaren gel can help them to control these pains. I put corticosteroid injection in red here. Corticosteroid injections should be avoided, and to me, it should be contraindicated to be put inside the tendon or at the tendon insertion. The reason being the steroids, first of all, as I said, there is no inflammatory response which we are trying to inhibit here within the tendon. The steroids themselves are a cause of tendinopathy, and a steroid injection in a tendon which is already failing will inhibit the healing response. So please do not forget that there's a good inflammation and there's a bad inflammation. Inflammation is required for healing. Whenever we get injury, the first step, the body's response to an injury is to create an inflammation there. In chronic phases of tendon healing, the inflammation is not existing, but in the early phases, the inflammation is good because it's going to bring all the vasodilatation, platelets, and platelets will bring all the platelet-derived growth factors and other healing factors. So inflammation is good. With steroids, we can inhibit that early inflammation, which means that we are delaying the healing response. In the chronic phases of tendinopathy, there's no inflammation, so steroids will have no role. Rather, steroids can have negative impact on tenocytes and collagen matrix, and it can predispose to tendon ruptures. We have seen sometimes cases where tendinopathy has been going on for some time, and as a response to injection, the tendon ruptures. But the role of steroid injection is in tissues which are around the tendon, such as that fat pad. If that is inflamed, the steroid injection will help with this thing. Or if it's adjacent to, for example, a subtalar joint, which is arthritic, and that is also contributing to Achilles tendon pain, an injection in that joint can help and take that component of pain away from them. So one thing is that to me, a steroid injection within the tendon is contraindicated, and I don't see a role for that. Again, I said, physiotherapy and offloading is basically trying to support that failing tendon. And the analogy is that as we grow old or we grow weaker, we may use a walking stick or a walking frame. What that means is that we transfer the load to that walking stick or walking frame, and that helps us to continue with our mobility and activity. Tendon cells respond to both mechanical and chemical signals. That is why the trend has been, since if there's any tendon rupture, is to repair the tendon or early rehabilitation or early mobilization, because there has been a considerable evidence to suggest that early mobilization responds to better healing, less scar formation, and better tendon properties. And if the tendon structure is restored, we're going to get a tensile strength which is adequate to take the load. Please don't forget, tendon have got elasticity as well. And if the tendon become too stiff with the scar tissue, that will cause pain, and that can cause predispose to rupture. So an elastic tendon is better. Some degree of elasticity is there. And the cross-sectional area gets better with this response to mechanical and chemical signals. Their collagen improves, the quality of collagen improves, the quantity improves as well. And that's why the combination of these will result in early resumption of activity. And then there have been some microscopic studies or at micro level shows that the DNA content increases in the cells, and in turn, the protein synthesis increases, which is all good. So all this is pointing towards better tissue within the tendon and less scar tissue. Eccentric exercises, there's a role for that one. And what does basically eccentric exercises means that tendon lengthens as it's contracting, and that's where the role of physiotherapy comes in. Stretching is important as well. So the stretching also results in some micro tears. Micro tears bring some microvascular ingrowth, and microvascular ingrowth brings the healing factor, and that's how it helps. And also it gives them elasticity and improves the tensile strength of the tendon. So there's a very significant role of physiotherapy, podiatry intervention through offloading, assessing the alignment of the foot, assessing the etiology, or at least addressing the mechanical factors, which are a major source of tendon pathology. There are some adjuncts which have been tried, and there's a long list of them. The reason being is not one shoe size fits all. And the treatment has to be customized and individualized to the patient based on their history, based on their risk factors, based on their physical examination, and based on their mechanical alignment. So every patient requires a bit more of the analysis of these factors. And one size, as I said, will not fit all. And we have to address these factors individually. Shockwave therapy, there's a considerable evidence again that it helps. Basically, it's a impulsive therapy used, which again creates a micro tears, brings vascular infiltration, brings the platelets, and then all the healing factors. Injection of platelet-rich plasma are becoming popular. And again, the main concept behind is that platelets are rich in factors which have got healing effect, like insulin growth factors, platelet-derived growth factors, vascular endothelial growth factors. So the whole thing is that they will stimulate or they will augment the healing response, which has not been either present or is not been adequate. GTN patches were tried again to improve the vascularity, radiofrequency ablations, sclerosing injection, laser therapy, all these, you name them, and they are available. But in the nutshell, when you look at the studies which examine them and they look at the role of each of these therapies, they sometimes do not find a considerable evidence to support the use of this thing. So what basically it means that they are adjuncts. They are not the primary treatment for the tendinopathy or plantar fasciitis. They are the adjuncts which you use to your other treatment strategy, which is again based on patient assessment, their mechanical modification, their physiotherapy and rehabilitation, and you use them to support it. Or you just, and this is the ammunition which you need to keep in your back pocket, but they're not the first line of treatment. They should not be the only treatment. They are the multimodal treatment which needs to be used. And there's usually a pyramidal approach for that one, that as you start with basic and broad treatment, and you start narrowing as you go a bit more into recalcitrant cases where the patients have failed to respond to the initial treatment. Surgery, I always say, is end of road option. And I tell patients that 70 to 80% of people who follow the multifacet regime for plantar fasciitis or Achilles tendonitis, they usually get better. We need to see the response. Yes, it can take up to 9 to 12 months. But if there's no response happening to your treatment and you're gradually increasing your adjuncts to them, then by 3 to 6 months, If they have not worked, it's not going to work. And then when you have analyzed that, you have tried everything, you have offloaded them, you give them a heel raise, you've done a physiotherapy, you've done the stretching exercise, you modified their risk factors, but there's no response happening, then you need to move on to the next step. You need to move up the pyramid. And the surgery comes in when they have tried, exhausted, and failed the non-surgical option, at least for, to me, about 3 to 6 months. And I usually observe their trend. I usually, whenever I see them, I ask them, how's your startup pain? How much walking you can do? How much pain you get at the night? Have you started resuming your activities such as running or jogging? And the patients usually give you a very good guide, and they can tell you whether things are working for them or not. In surgery, basically what we do is that we go into the tendon, we excise the scar tissue, any degenerated tissues, and we try to stimulate, again, healing response by creating some micro trauma, which will bring the vascularity. And that vascularity brings some healing cells, such as platelet cells around there, and they can initiate or potentiate the healing response which is happening. The picture on the right side is for the tendon, mid-substance tendinopathy, and you can see is that basically it's a scalpel blade which is within the tendon, and it is used to excise any tissue which is not healthy there, and you can visually see that it's a non-healthy thing. Or if there's any calcification focus which has formed in there, you just remove it, and then you create a surgical trauma which will initiate the vascularity and healing response. For the insertional one, it's a little bit more complex, but this surgery is usually very effective. And 80 to 85% people who have failed the initial treatment or non-surgical treatment respond to it. Again, what we do is that we split the tendon in the middle. And as I showed you that X-ray there's some bone which was formed at the back of the heel. There was calcification in the tendon. There was bone which is formed within the tendon. That gets removed. We create a raw bony surface, which is cancellous bone in the calcaneum, which is bleeding. And we put these anchors, and that's called a speed bridge technique. And we attach the tendon into the calcaneum. And again, same thing, we have removed all the devitalized fibrotic osseous tissue. We have stimulated a vascularity and healing response, and that will help to create some healthy tissue, some nice scar formation, which makes the tendon a bit more elastic, and it prepares it to take the load. And even after the surgery, we have to supplement it with a good physiotherapy, a good podiatry intervention to keep that offloading and the support of tendon to going on. So, and the surgery-wise, it's usually, the reason we put the surgery towards the end of the road option is that a few reasons. Number one, 80% of the people get better with non-surgical options. 20% who are not getting better, they have tried everything and they are the candidates for surgery, but they are usually people who can be high risk, such as diabetics. Diabetic people have got more risk of wound breakdown, infection, poor quality tendon, tendon not healing, risk of rupture. Then after surgery, they have to be placed in a plaster for 2 weeks, then in a cam boot for 6 weeks, till the 2 weeks requires for the wound to heal. Swelling can occur, which can take months to resolve. And also you have to put some hardware in there, and that hardware can sometimes cause irritation. The vascular supply to the skin at the back of the heel is not very great, particularly in diabetic people or people who have got some previous vascular issues. And also, there's no enough skin to play at the back of the calcaneum. So if the wound breaks down or infection happens, then it can have catastrophic outcomes, which can cause to either osteomyelitis in the calcaneum, and a very worst case scenario could even lead to severe infection and may lead to even amputation. These are the real, although very rare, but real catastrophic risks. So you have to, again, rationalize and individualize your approach to a patient, whether they are candidate for surgery or not. And as I also said, that when surgery happens, you have to immobilize them. that results in wasting of calf muscles. So rehabilitation is not only aimed at supporting the tendon healing, but it's also aimed at regenerating the calf muscle bulk and getting the muscle strength back again. And it can sometimes prolong the recovery. But it has got a role in people who have failed the non-surgical option. And as I said, the results are 80 to 85%. There's future looking around there. We're looking at stem cell therapy now, trying to regenerate the tendon cells, tenocytes in laboratory, and implantation, gene therapy. These are all in experimental thing. And I just wanted to a little bit say that these are all in infancy or still in experimental phases. But when these will come in future, then hopefully we can see an improvement in the quality of the tendon we can create, and we can actually try to create a bit more normal looking organic tendon tissue, rather than at the moment we're relying on a good scar tissue and a mixture of collagen and tenocytes. So we can go a bit more physiological loading and more physiological tissues which can be loaded physiologically and then healing up there. But that's in future at the moment. Just very briefly on plantar fasciitis. As I said, it's closely related to Achilles. And nowadays, the belief is that the mother of the evil is Achilles, and plantar fasciitis is actually a symptom or is an effect of that. Same risk factors, which are for Achilles: diabetics, hypertensive, contraceptive in women, high BMI, aging, poor exercise, a sudden increase in activity. And as Sam alluded, it resolves within 9 to 12 months, and it responds well to offloading strategy and physiotherapy. Now, very exciting. I think I'm sure this is something which excites you as well when you see the X-ray and the report says calcaneal spur. Now, calcaneal spur is let me just a little bit clarify on this thing, that calcaneal spur is not the cause of plantar fasciitis. Rather, as we have explained in setting of Achilles tendon, is the chronic plantar fasciitis and chronic tearing of the plant or chronic stress at the insertion of the plantar fascia has resulted in that bone or that calcification and ossification happening, which resulted in spur. This is a paper in Foot and Ankle International, and I looked at there, and they just found one thing, is that if you look at this table, that there are different type of spurs, like whether it's present, if it's present, either it's horizontal, as on the top left picture, is it vertical, which is on the top right picture, and there is also there's also this hooked one. But when you look at their pain score and you look at their pre-intervention foot and ankle score, there was no significant difference. So whether the spur is present or not present, it is irrelevant in the management of these people. Spur, sometimes you will see a spur present, but patients have no symptoms. And sometimes patients have got characteristic plantar fasciitis symptoms and there's no spur. But they found this thing that after intervention, which was standardized for across all the plantar fascia, it was nothing to do with the spur. People who have got this hooked spur or a vertical spur, they improve better than the horizontal spur. So these 2-3 studies actually negated the effect that spur is not the cause. Spur is rather a byproduct of plantar fasciitis, and it has no significant bearing on the pre-intervention symptoms. But some of the spurs respond better after intervention, but that intervention was not directed at the spur. The intervention was directed at the plantar fascia. Same thing, NSAIDs cryotherapy. Corticosteroid injection in plantar fasciitis may have some role, because here we are not dealing with the tenocytes around there. But again, multiple corticosteroid injection or a corticosteroid injection given in the plantar fascia can make it weaker and can result in the rupture. So the injection has to be targeted with ultrasound and should be around that area rather than inside the tissue itself, because steroid inside the tissue can make it weaker and can predispose to rupture. Same adjuvants can be used as for Achilles tendinopathy. It's the same slide I've just repeated. There have been role of shockwave therapy, and I have sent people for shockwave therapy after they have tried and failed the other options, and they have responded. But again, shockwave therapy has to be carefully planned. It depends, again, what the size of the tear is, how big is the tear, what's the etiology, have we addressed the other mechanical and biological factors before we are allowing this one. And then 4 or 5 sessions for these ones, and then we need to see and monitor the response. Monitoring response is very important, which will see whether some treatment is working or not. Platelet-rich plasma, again, as there has some role around there, but there's some people who have tried everything and it didn't work for them, and we have to go to the surgical option. Plantar fasciitis surgery is basically of 2 types. One is targeting the plantar fascia, which is like the picture on the right side. And basically, again, what we do is that we go in and we just create a small incision or cut in the plantar fascia. The important here thing is to realize that the whole of the plantar fascia should not be cut. Otherwise, as I explained to you, plantar fascia is important for the arch of the foot. And if we divide all of the plantar fascia, it will cause a loss in the plantar arch, and that may not help. It will cause the loss of plantar arch, but it may not help with the symptoms. So we do a partial incision or partial resection. There's one technique which I normally do is that I use a sharp needle under sedation in theater, and I create micro tears on the medial side of the band of the plantar fascia, but I do not go beyond 50% of the thickness. And I inject at the same time the PRP into the plantar fascia itself. It's called as needle scarification. It is giving me good results, and my trainer in Sydney, he used to do that with very good results as well. It's a simple procedure, day case, but has to be done under heavy sedation because it's quite painful, because you're causing that one again. It doesn't require general anesthetic. And there's a tiny wound, a needle again, so no significant risk of wound infection or breakdown, and it gives good results. But the recent trend has been, again, as I said, that plantar fascia, we are thinking it could be the effect rather than the cause. And the cause could be the tight Achilles tendon. And gastrocnemius recession, and in patients who have failed all those treatments, I have lengthened their Achilles tendon, and they have got good result from it. And there's this paper, systematic review, which was published in 2021 in Foot and Ankle International, supported this evidence that these are different types of gastrocnemius recession, which means basically lengthening of the gastrocnemius fascia, has got a very positive impact on plantar fascia. And that again supports this fact that the Achilles tendon is actually driving force for plantar fasciitis. One other thing as well, if we should not assume every plantar pain, heel pain is plantar fasciitis or Achilles tendonitis. It can really, but sometimes be some other pathology, which can be overlooked or missed. Calcaneal stress fractures, again, because the etiology remains the same, happens in athletes, runners, people who have not been previously active and have started resuming doing activity. I'm classically seeing in middle-aged men and women who wanted to just have this drive to get fit, and they started their fitness process, either going to the gym or running, and then they started experiencing all these symptoms. So calcaneal stress fracture is an important differential. And that is very well picked up on MRI scan. X-rays can sometimes miss it because it's a bone edema in the calcaneum. And that has got a different line of management. There's a nerve which arises from the tibial nerve. That's called as Baxter's nerve, that crosses the calcaneum. If that's entrapped, that can present with a plantar medial pain. And this pain is very similar and it mimics the plantar fasciitis. But the main thing is that there's patients in this one describe not only the burning pain, but some periods of altered sensation in the sole, which can be intermittent and progressively worsening, or around the heel area, they complain of numbness or so around there. Again, MRI scan at a dedicated center, which is reported by a musculoskeletal radiologist, is the one for the diagnosis. Same thing is tarsal tunnel syndrome is actually behind the medial malleolus. There's a retinaculum, the tibial nerve and artery goes underneath it. And they can also can be trapped. It's just like carpal tunnel or cubital tunnel, and patients can present with plantar medial pain. In cases of trauma, the heel fat pad inflammation, heel fat pad necrosis, and or if there's any previous history of trauma, such as if they jumped from a height, landed on a hard surface, that can also cause these issues. And also we need to make sure there's no referred pain from ankle joint, from subtalar joint, or sometimes radiculopathy can present there as well. And last but not the least, infections and tumors, they can also occur, like sarcomas, the synovial sarcoma, which is one of the commonest foot and ankle tumor, and they can present with this one, and there could be a delay in diagnosis if you're treating plantar fasciitis. So these are some things which we need to keep in mind, that when we are dealing with plantar fasciitis or Achilles tendonitis, that we are not overlooking these aspects. That brings to the end of the talk, and thank you very much for your attention. I really appreciate it late in the evening for your attention.
Thank you very much, Saqib. I think we'll all be looking at plantar fasciitis completely differently now. We've got time for a couple of questions and then we better wrap it up. So the first question is, what is the role for Achilles rupture surgery in a middle-aged female tennis player? So the Achilles tendon's ruptured and wondering about the role of surgery in a middle-aged female tennis player.
So for the Achilles rupture has attracted a lot of attention, and the treatment is being, what I said, jury's still out, which is the best or not. When I look at some person and decide about the surgery, so I want to check with them is that, number one, what was the mechanism of their injury? And number two is that what are their aspirations and expectations of returning to the activities? And also the other thing is to consider in this is that if they accept, and also their compliance. If a non-surgical option is taken in Achilles rupture and the patient is quite compliant and they accept that there is a role, they accept that the risk of re-rupture is only a couple of percentage more, then non-operative treatment for them works. But if they want to return to a high impact activity, as you said, tennis player, this rupture, Achilles rupture, has been initially misdiagnosed. They have not been adequately immobilized in plantar flexion, or the patient wants to go return to high demand activities, then there's a role of surgery for them.
Right. And then we have another question, which is, where can we refer for shockwave therapy in Canberra?
Okay, so there are a few clinics around Canberra which do offer shockwave therapy, but my suggestion would be, from general practice point of view, is that before directly referring to shockwave therapy, it's better to get them assessed, because again, as I said, shockwave therapy is not for everyone. We need to perform an MRI scan. We need to assess the degree of the tear. We need to assess is there any other factors which can be modified. And shockwave therapy should be an adjunct to the treatment, which is physiotherapy for dietary and offloading and stretch and rehabilitation with them. So it's an adjunct, it's not the isolated treatment. So right. Once we have done that one, then we can use shockwave therapy as an adjunct. But there are places who do shockwave therapy in Canada.
So just Google them, or are you aware of any locations?
I think the walking clinic is doing this one, and we have our podiatrist starting with us as well, and we will be introducing shockwave therapy soon as well. So, but the walking clinic, or there's a Canberra heel pain clinic, they do these shockwave therapies here. So you can just contact them.
Right, the walking clinic. Yep. Yeah, and so possibly other podiatrists as well might do it. Matt has said podiatry, podiatry professionals, Canberra, heel pain.
Yeah.
Yep.
And one of our podiatrists, Emma Reeder, I think she's on the talk as well. She's also licensed to do the shockwave therapy. But I think we are in the process of setting it up. But again, it is an adjunct, and it has to be like a second or third year of intervention.
Yeah. And this is a bit of a controversial one. Is there a role for anabolic steroids in tendon repair and healing?
Question is, yes, there's a role, but it's a negative role.
Okay.
I was going to say, I've seen a few patients with ruptured tendons post a cycle of anabolic steroids.
Right. Yeah.
So they're actually predisposed to tendon rupture, and they slow down the healing, and the quality of the scar tissue or collagen we are looking for, they affect that badly, and that affects the tendon quality.
Yeah.
Just one last question, and this one's from me for Sam. So as a GP, I'm not very good at assessing what is a lax ligament and what is not a lax ligament. Have you got any tips for helping GPs to say, yep, this one is kind of more lax than it should, or this person has got a hypermobility condition, and so the laxity is just part of their hypermobility versus it being a tear?
Yeah, so I guess like the biggest thing is always left versus right for that person. So I'll never feel or test a ligament where I don't test the opposite side, because if that person is naturally lax or is naturally hypermobile, then you're not going to get any more information by just testing one ankle, because you could think, oh, that feels really loose, but if their other side is really loose as well. So I guess when I'm looking at it, it's always in respect to what I think is left versus right, but also a general sense of testing however many ankles I've tested of where I think they should be. I guess when it comes to kind of hypermobility, if that's the condition, or if they kind of have EDS or something like that, then that changes as well. But mainly it's just keep feeling ankles, keep testing ligaments, and get a sense for where you feel like they should be, and then compare it to their other side.
Thanks. One last question, and then we better wind it up. So offloading, does that mean always crutches or a walking boot?
Offloading is actually a spectrum. So in the acute phases, we can offload by, if it's a severe pain, acute pain, then you can offload them by making the non-weight bearing or camel. But what we meant offloading is to give them a heel raise or an insole, which keeps the foot in slightly plantar flex posture, so that the tendon is not in a stretched position as they're walking. And that will just offload the tendon in a way that it's not getting those forces which are acting at its insertion to the calcaneum. So you can offload it with a heel raise, which help with people, but then that has to be looking into their foot, whether it's a flat foot or it's a high arch foot, because that has to be dealt with orthotics. But acute phase, cam boot is a good one for a few weeks just to let things settle down.
Right. Thanks. Okay, we better wind it up. Thank you both very much for such excellent presentations. We've all learned a lot. The next physio webinar is scheduled for 7 p.m. on Wednesday, the 10th of April. So please save the date. And we have physiotherapist Matthew Kroger and orthopaedic surgeon Catherine Cordier presenting on the management of common shoulder pathology, including rotator cuff injuries and adhesive capsulitis. CHN will send out the evaluation surveys shortly. Please fill in the post-event evaluation survey so that CHN can email you a certificate of attendance after the event. And please feel free to self-report 1.5 hours of educational activities to your CPT home. And we'll put the resources and presentation slides and a YouTube recording will be emailed out to the participants who complete their evaluations. So thank you both very much again. And that was really, really useful. Thanks. Bye.
Thank you.